What the spine surgery in the U.S. right now, the market is huge, and as you see here, the annual spine volume is going up, and so there's no really no slowing down right now. And as the patient population's age, as you see, and we primarily most of what we do are degenerative spine diseases, and you see these volume going up, and the trend though, as you see though. The inpatient volume is slowly decreasing, and it's projecting to be decreasing, all the way till 2020. And also, the other thing being that the trend is that more and more spine surgeries are being, moved over to the outpatient setting, and that allow us to do more, more highly technical procedures, minimally invasive things. Part of it is these imaging technologies. We have these neural navigations, all kinds of gadgets that allow us to see things without actually seeing things, because you're going through small incisions, and so the anatomy, you really have to know what your anatomy is. You can't see everything like you traditionally would. I will show you some of the examples, but a lot of these image guidance, robotics, that help us in terms of allowing us to do things, without having to actually seeing things, and allowing us to guide us through the spine anatomy. And other things are developing too. So not just we're just not stuck in the traditional surgery realm, but moving into stem cell research, regenerative research, trying to regenerate some of the degenerative things. Most of the work is in the disc area. When you're injecting medications to the disc and try to regenerate that. But there are a lot of research going on in that as well. So is minimally invasive surgery less surgery? Does that mean that we're doing less? Not really, because you're still needing to accomplish the same thing. You still have certain objectives that you need to accomplish in surgery. So just because it's minimally invasive doesn't mean that we're cutting corners. We're not doing what needs to be done. So so you have to make sure that you're still doing the procedure, but at the same time, what you are trying to accomplish is less tissue damage, and by decreasing morbidity, and hopefully you have a more rapid functional recovery. And those are the objectives. And so what are the things that you can measure, right? So some of the objective things. So certainly, you want to reduce the tissue damage. Some of the measurable clinical outcomes, most of the research papers that you'll read comparing minimally invasive surgery to traditional surgery, things that we compare to, intraoperative blood loss, operative time, surgical mobility, the amount of pain medicine that they need, length of stays, and how soon they can return to their activities. Those are the things that we can objectively measure, right? So to see if this thing works or not. I think intuitively, minimally invasive surgery does work, and they're effective and they're safe. But now I think today, now in 2014, I think there's enough data out there now we can effectively say that minimally invasive surgery does work. They're effective, they're cost effective, they're safe. Under the right hand and the right facilities, I think they do work. So this is the open traditional surgery. So we're going through this muscle again. We make an incision here and we strip that muscle off, or sometimes cut that off, and so when you do a laminectomy or something like that, you see how on this side here, this multifidus, this muscle is still here. And sometimes once you cut them or de-innervate them, they atrophy. They just go away, and it becomes a hole there. Actually, it fills usually with fatty tissues or scar tissues there. Versus in this patient here, this is one of my patients here that has a minimally invasive surgery where she had a laminectomy here. We kind of drew out the lamina. I just kind of picked this cut here. But most of the muscle is relatively intact, you see. Just this part here that I was working on. So basically you use sequential, there's these tubes. So instead of cutting through the muscle, you're basically spreading them around. So I don't know if any of you have seen these type of things. So it's just slowly, basically just spreading the muscle slowly apart. And then you kind of work in between the muscle fibers instead of cutting them. And so you're not cutting through the attachments, you're kind of working in between. And in order to see things, you need some kind of light source. I use a microscope. There are guys that use endoscope. You know, you can use a little camera that goes down there. and that allows you to work under that through the tube. So this is the most common thing that if you see people, hear people about doing minimally invasive surgery, laminectomy, discectomies. It's kind of like we do it through a tube, so it's kind of this type of system. You want the safest route and the least invasive route. So there are techniques where people are doing regenerative therapies to these tubes. They have make a bigger tube, so people that if you can accommodate those bigger tubes, you can actually do a fusion through those tubes now. So there are techniques out there that you can do. So I'm not saying that you should do them, or surgeons should be doing them. I know, again, we're going back to just because there's a toy there, there's a technique there, it doesn't mean that we should be doing that. We obviously need to look at the outcomes and make sure that this is a procedure that's good for people. But the main thing is, got to know what you're doing. Again, like I said, kind of going back, I'm trying to kind of loop it around. Many surgeons are nowadays advertising they all do minimally invasive surgery. Everybody does minimally invasive surgery, but you got to see what's minimally invasive about it. What kind of surgery do they do? How do you treat the tissues? This is relatively new. So this endoscopic approach. I mean, it's not new in the orthopedic world. People have their shoulder scopes, their knee scopes. But now we're able to have the instrumentations that's needed, the optics that's needed, that you can actually scope the spine. And so the question will be, why do you want to scope the spine? What can you do? And then how do you do it, right? And so it's a complete different anatomy, different thinking. So for a traditional spine surgeon, this is a complete different way of doing things. And that's why it's not widely adopted procedure. But definitely I'm sold on this procedure. I've done these procedures, and we're the only place in this area in Central Ohio that do these type of procedures. And I think with experience and with training, I think this procedure has a lot of potentials. So what can you do? You can do a lot of things. So you can see the disc, you can see the nerves, you can see the epidural space, you can work around the facets because you're right underneath the facet, so you can actually treat stenosis. Stenosis, people have these hypertrophy facets and things, whatever that's in the foramen. The other things being the medial branch comes out here. So when people have facet joints, there's the nerve that comes out of the invasive facets. There's a medial branch. Those are pain fibers, and so you can actually do rhizotomy. People have ablation, nerve ablations and things. You can actually go in there. So the nerve ablation, the pain guys, they do it. They stick a needle in there, right? And then in the simplistic way, they basically heat that area up and kind of burn that nerve, right? And basically stunts that nerve, and then eventually they'll grow back. And then in this technique, you can actually go in there with a scope. You can actually see the medial branch, you can see the nerve, and then you literally burn it, you can cut it. And so it's actually a little bit more effective, meaning that it lasts a little bit longer in terms of pain relief. And so there's certain things that you can do around there. So again, this is kind of what a picture looks like. So instead of going to the lamina here, you're directly targeting the disc that's herniated out, but it's kind of more from the side. So the incision is kind of more here, right? So same thing, the way we do it, same thing. Basically, there's a guide wire, and then you basically dilate, different tubes that go and dilate it, and then you leave this cannula here, and then the scope that comes out. Then you have the irrigation, you have the water going in, and then outlet where the suction is. And then in the scope part here is got a couple of working channels here. That's where you can put your instruments in there. There are different instruments that you can go in and grab things. You can drill, you can remove things. So yeah, I mean, if you are not careful, you're looking at that, oh, that's somebody's scoping the knee or shoulder or something. So this is actually a spine.
So with the degenerative disc, what's happening is the nucleus pulposus, the gel-like collagen material in the center of the disc, is basically you have advanced cross-linking and loss of hydration, the water content, and basically this soft material becomes harder and stiffer, and basically starts fraying the annulus fibrosus fibers surrounding the disc nucleus. That also starts fraying, and then the disc basically degenerates. And that can cause a cascade of inflammatory processes, and the end result to the patient, this sounds all fancy, but to the patient, their back hurts, and in a chronic basis. Initially, back might hurt here and there, take some Advil, leaves, goes away. A year later, same episode. 2 years later, same episode, except it lasts longer, on, and so on and so forth. And until it gets to a point where they're losing time out from work, and the pain is, and the episodes occur with increase in frequency. And so, the most common thing we start with, when I see a patient, is first is conservative treatments, anti-inflammatories, exercise, physical therapy, epidural injections sometimes can be useful, but then there comes a point where you might have a relatively young person who's working, and this has become very debilitating, and they've tried pretty much everything. And so we start talking about a fusion. The concept behind that is to remove is to stabilize that one segment or whatever number of segments have these degenerative changes. And we do that and you can do that several ways. One is you remove that disc completely, pack that with bone or a spacer. And then also to provide support, we provide instrumentation by putting in screws, rods. And so that's the basic concept for the fusion. So we would make a long midline incision, dissect the paraspinal muscles away from the spinous processes and the lamina, and then we expose the facet joints, and then that allows us to put in the pedicle screws. And let me just show you this model here. So this sort of represents what I'm talking about, where the spinous processes would strip away the paraspinal muscles, and then the pedicle screws these represent the pedicles here. So the screws would then be directed at the pedicles here. And so if you look at this, you can see in order to put screws here and here, you make a midline incision, you need to basically open up like that to get at both sides. And so one of the concepts of the minimally invasive spinal posterior lumbar instrumentation system is to try to be able to put in those screws without having to come in the middle and then strip everything open. So we've gone from a complete wide open exposure to putting in screws through these guide wires. And then once the screws are in place, then the hardest part is then how do you get this rod in there over the screws? I mean, it's fine just putting separate screws in there, but then, and so again, through a smaller incision, once the screws are in place, the idea is you would slide this through in here, and then as you have several screws lined up in here, you sort of wind this rod through the several screws there, and then the cap, and then start placing down through here, and then basically you would put the cap, which is this top blue thing. You screw that on through that, and then that's how that minimally invasive instrumentation is accomplished. And the idea and the advantage of that is, Dr. Chen talked about, is the soft tissue dissection. And I've said this many times, but it's quite a bit of dissection to move these tissues apart this way versus several stab holes and then winding that rod through the stab holes.